Thank you so much, madam, and good afternoon to everybody. Angle closure is an enigma because of its varied causative factors, clinical presentation, and response to treatment. No two patients respond in the same way. And our understanding of angle closure has improved because of this ability to visualize angle structures and quantify them with ASOCT and UBM. So what is the basic difference between POAG and PACD? Like, normally people think, all right, the angles are closed, and both of them people think as just two separate glaucomas. But the aim in primary open angle glaucoma is to lower the intraocular pressure. But in primary ACD, angle closure disease, our aim is to prevent angle closure. And by preventing angle closure, you prevent the pressure from rising. So to a certain extent, PACG is preventable, POAG is not. Okay. So another thing, if there are many times when people come to me and say that this patient had mild angle closure. One more thing I want people to understand is that there is no concept of mild angle closure. Whenever you see a patient, you do a gonioscopy, and you try to club the patient in one of these three primary angle closure suspect, which means there is only iridotrabecular contact, there are no PAS, there is no glaucomatous neuropathy, and then you do not need to sort of treat, but you just need to follow up. The second is PAC. Even a person who has had an acute angle closure attack goes into this criteria of primary angle closure. And of course, glaucoma is when you have a defect. So this is one more thing which I want you to understand. Whenever you see a patient, you try to classify the patient in one of angle closure, and then you will know what to do. PACS, observe, PAC iridotomy, PACG iridotomy, and treat the person as you would do a POAG. So what are the anatomic risk factors? We all know traditionally, small cornea, shallow anterior chamber, thick lens, anterior lens position, short axial lens, all these are anatomic risk factors for developing angle closure. But everybody does not develop, even nanophthalmic eyes don't always develop angle closure. So we have had certain modalities like the OCT, the ASOCT particularly, which gives all these measurements, and some of these measurements have shown to be, these patients with these measurements are at a higher risk of developing angle closure. What is the role of the lens? Everything that we know. So one is a more anterior position, then a higher vault. Vault means, in very simple terms, how much it protrudes into the anterior chamber is the vault of the lens, plus the position of the size of the lens. It's a large lens in a small eye, and even the thickness of the lens has a role to play in the development of angle closure. What is the role of UVEA? Now, this is something which we have been able to elucidate more and more because of using ASOCT, and more of ASOCT and very little of UBM. So one is that when you dilate a pupil, the iris acts like a sponge and sort of squeezes fluid out of the iris. But in a patient who has angle closure, it increases in thickness. So this is one, iris volume which usually decreases in patients after dilation. Here it increases and thereby crowds the eye further, and thereby the person can get an angle closure attack. Then all these other things that there is differential iris thickening, that the iris which is nearest the ciliary body thickens as age increases. Choroidal expansion is sought to be another very important cause of angle closure. Means choroidal expansion sort of crowds the eye, the iris lens diaphragm is pushed forward, and that is what precipitates an attack of angle closure. So these are the roles which different organelles inside the eye play. Now, this is what, there are questions which we have always asked. Now, there is this 40-year-old lady who came to me in 2010. I advised YAC PI because the angles were closed. I dilated her in 2012, 2015, nothing happened, the pressure did not rise at all. And I was worried, I mean, not worried, I was questioning myself that how come I had stopped telling her also about the PI. And in 2016, after I dilated her, the same evening she came with an attack. So I thought 6 years nothing happened, even though anatomically, gonioscopically, I felt it was the same. There was one more patient with primary angle closure, and I could not complete the iridotomy in one eye. In the other eye, I could do that. But 4 days after the attempt to iridotomy, he developed an acute attack. So what happened that a patient who was otherwise doing very well, why did he have an attack? If I had probably left him alone, he would have been better off. So these are the questions which we ask, and we see two patients, similar closed angles, and they don't develop any attack. So there is this very beautiful diagram which tells you what happens. Now all these questions can be answered by this diagram, that the genetic makeup of a person decides the structure of the eye, including the cornea, crowded anterior segment, and everything which predisposes a person to angle closure attack. These form the groundwork on which all subsequent factors, when they come into the right proportion, they will precipitate an angle closure attack. So which are these? So it could be, the main is aging. When a person ages, this lens wall, the lens thick, and the anterior lens position actually comes into a more favorable position where it can precipitate an acute attack. The patient in whom I had an imperforate iridotomy, probably the iris thickness crowded the angle, and a person who was otherwise asymptomatic developed an attack of angle closure glaucoma. So this is one thing which you have to realize, that even though a person may have all the anatomical predispositions, unless other factors come into play, like if he develops a cataract, probably even though he has the anatomical groundwork, if he gets operated, he's never going to develop the attack. So this is what is a basic understanding of angle closure glaucoma, why some people develop it and why some people don't. Now, so mechanism of angle closure, pupillary block is the main commonly known mechanism of primary angle closure. It is due to the proximity of the posterior surface of the iris to the lens, which generates an increase in aqueous flow resistance, and we all know what happens after that. However, there are non-pupillary block factors like whatever I said earlier, thick peripheral iris, anteriorly rotated ciliary body, plateau iris configuration, serially blocked. So when you do an iridotomy, you relieve only the pupillary block. The rest, and however, there are studies which have said that half of the primary angle closure in this Chinese patients, the study, 54.8 was caused by multiple mechanisms. So always the patient will not have just one mechanism, but of which pupillary block is a main mechanism, and hence iridotomy should be advised in each patient. But however, as I have told you earlier, it will address only the pupillary block, and response to PI will be determined by the contribution of the pupillary block and the contribution of the other factors. So why do some people develop acute attack, or why in the same patient only one eye develops an acute attack and the other eye does not? So again, as I said, the earlier diagram which I referred to, that patient, even though the anatomy might be the same, a millimeter difference in the ciliary body position or the lens position could sort of predispose only one eye to an attack and the other eye would be all right. So it is said that why some patients develop acute attack, and that is because it's a small eye. Eyes with acute attacks are smaller as compared to the other eyes. So to summarize, angle closure is an anatomic disease of small eyes. Pupillary block is just one mechanism. The anatomic and physiologic changes of the iris in the choroid play a great role. We still don't know why some people develop a chronic disease and some develop acute attacks. There is also a fact that if there is no lens, there is no primary angle closure, because the one organelle which sort of crowds the eye, that you have taken off. So thank you very much for a very patient listening. Thank you, madam. Thank you once again.